Good afternoon, everybody. Thank you for the invitation. I appreciate this. This was the title that was assigned to me, but those of you that know me know that I will not be shackled by the constraints of authority. So this is what I'm actually going to talk about. And I think this is a better way to understand the value, not only in GERD therapy, but all therapies, and more importantly, how to talk to the various stakeholders. So these are my disclosures, none of which are relevant. Okay, so to assess the cost benefit of a laparoscopic anti-reflux surgery from the perspective of each stakeholder and discuss why alignment of these cost benefit perspectives is essential in making the business case for surgery. So this is the typical surgeon's business plan. Hey, I want to do a new procedure X, which is awesome. You go to the hospital. If you buy me all the equipment for $14 million, I'll bring you all these patients in, and I'll pay for itself in no time. End of plan. And how well has that worked for us? Generally, not too well. And now it's say that's because we don't understand the perspective of the hospital. This is the typical value equation that I'm sure everybody in this room has seen, and I will tell you that it's sophomoric, and you probably should stop thinking about this one. Because there's no universal definition of what is quality, and no matter how poor the quality, as long as it's some finite number greater than zero, as costs go to zero, that value goes to infinity. And yes, that's how humans have lived their life, lo these many millennia, but it's not really, I think, what we want to define quality. Because in that case, then the best value would be no medical care at all. This is how academics and some healthcare agencies think about cost-benefit analysis. It is a societal-based approach. That is, how do we provide the most benefit to society as a whole with the limited resources that we have? It's measured in money spent to achieve a particular outcome. Generally, the cost per quality-adjusted life year gain. $40,000 was generally the accepted value, although that varies depending on which authority you want to read. So I have a question for the audience. How many patients have you seen where when they sit down and talk to you about their problem, say, "Doc, I want you to do what's best for society"? I don't see them either. Maybe in Canada, Jerry, but yeah, all right. So a couple years back, I gave a talk about, I was assigned to have a kind of similar thing about how do we measure, what should we be measuring as outcomes for minimally invasive pancreatectomy. And Jim Mosier cornered me, and we ended up talking about this, the different perspectives of the stakeholder. And so these are the stakeholders that in general we think about when we think about operations, and it's the patient, the surgeon, the hospital, the employer, a private payer, government. You could probably throw industry in there, although I'm not going to talk about it. And we came up with a set of valuations. And what I'm going to talk about is kind of based on this. So I'm going to spend a little bit of time here about these value propositions. And so we're going to talk about the patient first. And this is what the patient is thinking about. Change in survival, which is probably particularly important in cancer patients. The change in quality of life, which in reflux disease is very important. Satisfaction with care as independent of quality of life. Their out-of-pocket cost. The income they lose because they've had an operation and can't work if they don't have a disability. The premium or taxes paid for health care. And ultimately, the unit there is quality-adjusted life year per dollar spent. For the surgeon, we have a little bit of different value proposition. We're concerned about our reputation, and because we do fancy operations, our reputation improves. We, of course, generate income by doing operations. We gain knowledge with each operation that we do. And if you don't believe that you can put a price on knowledge, then you probably should return your registration fee for this meeting. Job satisfaction, because we like to operate. Then the more mundane things, the cost of practice, opportunity loss, because if you do one operation, it means you can't do another one, and the effort expense, and basically is the dollar amount per hour of effort. For the hospital or healthcare facility, again, they have a different value proposition. Hospitals have reputation. It matters to them. They generate income. They also gain knowledge or experience for their operating room staff or other members of their hospital. And by doing that, it becomes more efficient. There's a cost to render care. They also have an opportunity loss because, again, if they fund your program, it means they can't fund another program. And they're going to wrap this around by a particular episode of care. And the unit there is dollars per episode of care. The private insurer is actually a little more pedestrian. They generate income through premiums. Of course, they generate income in other ways through investments, but we're going to simplify it to just the premiums. There's a cost to payouts to the providers in the hospital, and they have a specific time unit for that premium covered, and that varies from a year where we have to re-up for that in particular insurance. So it's dollars per year. The employer is a little more complicated, where he's concerned about the income generated by the productivity of the worker prior to the health intervention. So because the worker is ill, there's the notion of presenteeism, where you know about absenteeism. Presenteeism is that the worker is there but not working optimally because they are ill. Loss of income when the employee is absent, is not being productive. The change in productivity due to satisfaction with the health benefits, so-called morale. If you have good benefits, you're going to feel a little bit better about your company. Then the I prime would be income generated because their productivity after their health has improved would go up. Cost to provide that benefit and time for that premium being covered. Again, it's dollars per year. The government, I'm not really going to talk about that. I don't know how to measure political capital other than votes. I just decided we're just not going to talk about that. So let's work through an example. You got a 40-year-old guy, and I'm going to make this a very simplifying assumption that this episode of care is the only care that the patient is going to receive for the year. In the United States, the life expectancy is 78 years. Median income is $59,000. The average single beneficiary premium is about just over $3,800 with a deductible of $4,300. And let's say the expected time off of work is about 3 weeks, which is about average after a lap Nissen. The expected quality multiplier, I'm going to put at 0.98. Now, so this is a utility score. 0 is death, 1 is perfect health. So I'm going to say we got him almost to perfect health with that lap Nissen. And I'm going to just make it simplified with that satisfaction of care being 1, not to complicate things too much. So for a surgeon, the average income we generate through our professional fees for a lap Nissen is just over $1,100. Lap Nissen is pretty common, but it does enhance our reputation. We're going to give that a multiplier of 1.1. The value gained, we're going to say about 50. Of course, when you're early on, when you start doing operations, every operation you do, the value gained by your experience is probably a lot more. When you're at your 5,000th and first, like Dr. Swanson, it's probably not so much. The value of satisfaction for doing operation, we're going to call it 100. Again, you can vary this however you want. The prorated cost for 2 hours by maintaining your office, paying your employees, paying the rent, making sure the lights are on, comes out to be about $261 for the 2 hours. I'm not going to talk about opportunity loss just because I wanted to simplify it. And let's say it takes you 2 hours. For the hospital, the income generated for a typical lap Nissen is just under $7,000, and then we'll go through the other reputation multiplier 1.1. We're going to call it 100. We're going to say, and the average cost to the hospital to do a lap Nissen is just over $4,300, and I'm going to ignore the opportunity loss just for the sake of this example. For the private payer, the income generated from employee-paid premium and the employer-paid premium comes out to be about $8,600 on average. And the cost for this episode of care is just over $8,000 minus that deductible that we talked about earlier. So about $3,700. Again, we're not going to talk about the government. The employer, we're going to go through this. The average employer share of a premium is just over $4,700. The average productivity of an American worker, there's actually data for this, is about $68 an hour. Let's assume that because they're refluxing and it makes them feel lousy, it reduces their productivity by 10%. let's also assume that when you get that lap Nissen and you feel great, it goes up by 10%. And again, for the sake of simplicity, we'll assume that this episode of care occurred in the middle of the year, just to make the calculations a little bit easier. And let's assume that their morale for having good health care improves their productivity by about 5%. Again, you can argue all these numbers. I understand. This is just an example we're working through. So what comes out to the calculations? For the patient, it ends up that it's 0.003 quality-adjusted life years per dollar spent, which is just about $1 a day for the rest of their life. So to get them to near perfect health for that patient costs them about $1 a day. For the surgeon, for those 2 hours we spent doing that lap Nissen, we made $640 an hour. Again, this is kind of simplifying it because you can then add post-operative care that will reduce it. For the hospital, they make a profit of just over $4,300. For the payer, just under $5,000, and for the employer, that employee generates just over $128,000 in productivity a year. So what does all this mean? The first and most important thing that I want to say is that the units of measure are different for each stakeholder. Having a somehow uniformed way to measure it that is the same for all stakeholders will get you nowhere. You have to understand what the stakeholder with whom you're having that conversation, whether it's important for them. And I'm going to be the first to admit, the values I gave in there are quite variable, and in fact, it's a little simplistic, because you could add other measures when you have more than one episode of care, for example, or what happens when you have a complication, what happens if the Nissen fails and there's a redo operation. All that changes the value propositions, but the general principle is the same. Also, the time horizon changes. I mean, for us, we're talking about how much money we get in an hour worth of work. For the patient, we're talking about the rest of their life. So understanding the value propositions is important. Now, I understand there's some limits to what I just told you. I'm not taking account any of the macroeconomic factors which might drive some of the decision, like for an insurance company being competitive with other insurance companies, the same thing for the hospital being competitive for other hospitals, or us being competitive with other surgeons who are providing care or procedures that we may not provide. So that kind of marks into it. And boys, we like doing operations, so we want to do operations. However, and then for any of these innovations, like I said, the margins will be affected by the durability. We had a discussion about other approaches to reflux disease yesterday that may not be as durable. That changes the calculus. So in conclusion, I think we need to think about value rather than volume, and that will be increasingly used to assess some medical care. It is important to understand the perspective of all these stakeholders because they will have different value propositions. And when you understand that, you start to talk in a language that makes sense to them. And as surgeons, our main interactions really is the patient and healthcare facilities and the payers, and they, as I said, all assess value differently. So thank you very much. And we're taking questions at the end.